Hey everyone, Dan Shepard, EMS Medical Director. So throughout the year, we're reviewing incidents, different cases, and sometimes we come across a topic that we think would be good to share with the group at large. So that's what we have for you today. We're going to review carbon monoxide poisoning. This is the outline. We're going to keep it pretty straightforward, only about 10 minutes, 12 slides. Talk about where carbon monoxide comes from, why it's dangerous, how we treat it, just the really important concepts. The reason carbon monoxide is so dangerous is because it's colorless, odorless, tasteless, non-irritating, so it can be present and you won't know unless you have a detector or you become symptomatic. And it's produced anytime you have the combustion of carbon-containing, incomplete combustion, I should say, of carbon-containing material. These graphics show sort of some of the more common sources and how they're broken down. So clearly you can see there are some residential sources, industrial, natural, sort of like a wildfire scenario, where you have that incomplete combustion. If you use one of those portable heaters when you're camping, something you certainly want to be careful with. They have these little propane canisters that could certainly be a source of carbon monoxide. So just to be so you can familiarize yourself with the common sources. Not something we see too commonly out here on the West Coast. When I was in Pennsylvania, certainly it gets a lot colder there in the winter, obviously, and we'd have fatalities every year, folks that become exposed to carbon monoxide, and so it's certainly a serious issue, definitely more so in other parts of the country than here on the West Coast, but not unheard of. This slide is intended to demonstrate the pathophysiology and why carbon monoxide is so dangerous, other than being really difficult to detect, other than with a detector or when someone becomes symptomatic. The reason carbon monoxide is so dangerous is because it binds so strongly to hemoglobin, so 250 times stronger than oxygen. So similarly, just as naloxone will come in there and displace fentanyl off the receptors, your mu receptors, carbon monoxide will come in and displace hemoglobin from hemoglobin. So now you got hemoglobin run through your body with no oxygen bound to it. The oxygen hemoglobin dissociation curve here on the left is this black line is your normal scenario. So on the x-axis, you have your partial pressure of oxygen. On the y-axis, you have the oxygen saturation. So if you have a lot of oxygen available in the blood and from the environment into the blood, then your oxygen saturation makes sense would be about 100%. As that partial pressure drops, so you go from arterial blood to venous blood, the amount of the partial pressure of oxygen decrease. You have your hemoglobin, your box cars as the common analogy. So they're carrying this oxygen around your body. And as you get to areas with low oxygen concentration, it's going to offload. So your saturation is going to decrease. And you can see here, this is that important precipitous line. So if you're doing a procedure and someone's got a high oxygen saturation, you make them apneic. As that partial pressure drops, their oxygen saturation drops, and so you can see as you get around 80, that's where it tanks and goes from 80 to 20 pretty quickly. This is why we peroxygenate folks. So the problem with carbon monoxide is it binds so strongly to hemoglobin, but it also decreases this curve to the left. So you need much lower oxygen concentration or partial pressure of oxygen for oxygen to be released from the hemoglobin. So it really, the bottom line is that you get acidosis and you get hypoxia. We get hypoxia to the tissue, which results in acidosis. And what's interesting about carbon monoxide poisoning, in addition to that, is that the symptoms can start off very nonspecific. So folks can have symptoms that could reflect any number of conditions: flu-like illness, maybe altitude sickness, kind of vague, just achy, dizzy, nausea, maybe some vomiting. They could develop some chest pain, and really, how severe their symptoms are really going to be related to their underlying medical problems. Certainly, someone who's older and has underlying health problems is going to become symptomatic or may have be much quicker to develop severe symptoms than someone who's young and healthy. But as you can see, it can start off very vague but get very focal and severe. So sort of the hallmark of carbon monoxide poisoning is vague and nonspecific symptoms. But you can ultimately progress to the tox triad of seizure, coma, death. This slide is just to point out some of the pitfalls, some of which we've already discussed. You really don't want to rely on the pulse oximetry. It can seem high, but it's really just hemoglobin and carbon dioxide, not hemoglobin and oxygen. So you can have a normal pulse ox, but the tissues can be quite hypoxic. And you want to, if you don't think of carbon monoxide poisoning, you're never going to identify it. So if you have, it's a lot of it is context. So you see, a heating source in the home that doesn't look safe. There's maybe a dead pet, multiple people sick with vague symptoms all at the same time. That's going to give you sort of a clue that you might be dealing with carbon monoxide. And oftentimes the symptoms don't correlate with the level of carbon monoxide. So someone, as I was kind of alluding to earlier, an older person with multiple medical problems might be a lot more symptomatic at a certain level than someone who's relatively healthy. Similarly, the prognosis doesn't seem to correlate with the carbon monoxide level. And you always want to think about cyanide. Whenever you have combustion, cyanide is a potential other toxic substance which can cause seizure, coma, death. So something you want to think of if you encounter a scenario where you're worried about carbon monoxide. And one of the other really unfortunate consequences of carbon monoxide poisoning is that it can result in delayed neurologic sequelae. And you can see how any number of these conditions can be really debilitating, especially if someone has dementia, Parkinsonism. So it's something that's it's really important that we identify and treat, because it can really, even with treatment, there can be some downstream consequences. It can really impact a person's life. And as I was saying before, the real trick to carbon monoxide is recognizing it. And then from there, it's really standard supportive care. You want to, if someone's really ill, you go with ABCs, CAM if it's indicated. And then after that, depending on the degree of, or the severity of the exposure, you're going to use benzos if they're seizing, push dose epi if they're hypotensive. But the cornerstone of treatment is oxygen, and we'll see why in a bit. But even from a minor all the way to severe exposure, you want to try to be aggressive with oxygenation, face mask, and really 100% high flow is sort of the cornerstone of treatment. And same in the emergency department. So we're going to, obviously we have the capability to escalate oxygen therapy and measure their levels with blood gases, so to speak. But oxygen is still the cornerstone of our therapy. And we will also consider hyperbarics. That treatment can be challenging logistically. It's reserved for folks who have an exposure, who have altered mental status, acidosis, levels greater than roughly 20 to 25. Pregnancy, those folks are going to be candidates for hyperbaric, but it can be challenging to get someone to a hyperbaric center. And this slide is really the one that demonstrates why we're so focused on oxygen. If I can move my head out of the way so you can see it. So the carbon monoxide, if you're just breathing room air, it's going to take hours for the half-life of the carbon monoxide. When you're on a non-rebreather mask, we can get it down to about an hour and a half. You can see there with hyperbaric, it's very effective. The studies are somewhat conflicting on how that changes the prognosis, but obviously, if someone's exposed to carbon monoxide, it's going to take hours for them to clear that on their own. So in the meantime, they're having decreased oxygen delivery to vital organs. So they really do need to go to the emergency department to get high flow oxygen therapy, because it's just not something that they can do at home, and it's really going to decrease the amount of time that they have this carbon monoxide in their system, which can decrease the chances of these delayed neurologic sequelae and other complications of carbon monoxide exposure. So if someone's been exposed and they're even remotely symptomatic, they should go to the emergency department for to have their levels checked and to receive oxygen therapy till they've cleared that carbon monoxide. So that's all I got. If you have additional questions, please leave a comment and we'll get back to you. I hope you enjoy the rest of EMS Update.